Okay, I'm going to go ahead and get started. It's a little past 12:30, and I want to give Chris his due time. It's a relatively unique day in seminar today. We have the public presentation of Dr. Chris Saffore's dissertation defense. This will conclude tomorrow with a closed hearing for with his committee, but today is a requirement that he gives a public presentation, and we're leveraging the fact that seminar is one avenue to do that. So it is my distinct honor to introduce today's speaker, Dr. Christopher Saffore. Dr. Saffore received his bachelor's degree from, I'm going to say, Missouri University, not Missouri. He then came here to UIC, where he received his PharmD and loved the people in PSOP so much that he went on to now almost complete his PhD with us. If he gets through the next couple days, he will be Dr. Christopher Saffore. He's going to talk to us today about, you can't clap yet, Brian. He's going to talk to us today about his work in the opioid epidemic and how he has essentially fixed it within the state of Illinois. So with no further, you said that earlier this semester. So with no further ado, join me in welcoming Dr. Saffore.
All right. Thank you, Todd, for that introduction. Hopefully I don't overpromise and underdeliver on solving the opioid crisis, but I'll give it, fixing the opioid crisis, but I'll give it my best shot. Okay. I know, why is it? I should hit enter, right, to go next. The next slide. There it is. All right, so I wanted to acknowledge my dissertation committee here. Dr. Todd Lee, Simon Picard, Lisa Sharp, Dr. Stephanie, the delightful Dr. Stephanie Crawford, and Michael Fisher, my external committee member. Now, if anyone needs a loan or cash advance, just want to let you know that with all of the millions of dollars of funding that the dynamic duo of Simon and Todd have brought in over the past month or so, please see them after this presentation. So next, I want to give some acknowledgements to a host of state agencies, national agencies, health systems, academic institutions, and our academic detailing team here at UIC. And a special acknowledgement to Dr. Mary Smart, who I would not have been able to, be here standing in front of you delivering this presentation to do our academic detailing program. So thank you, Mary, for the blood, sweat, and tears over this past 18 months or so. Okay, so the outline of the presentation today, I'll give a background about the opioid crisis, talk a little bit about what is academic detailing, where are the gaps in the literature, conceptually how does this all fit together, then talk about our program, the findings from my 3 aims, and then overall and direct implications of this work. So by show of hands, how many of you guys have heard of the opioid crisis? Majority. Okay, great. So this will be a breeze. This will be a review for you. So the CDC has sort of grouped the opioid crisis into 3 separate waves. And the wave that is of most importance is going to be the first one as it relates to opioid-related mortality related to prescription opioids. By the numbers here, this is data from 2016. The one for 2017, which is the most recent data that's available, it didn't sort of convey the information that I wanted to. So I'll provide the updated numbers here. So we can see that it says 42 here, but there were actually an increase, 47,000 deaths related to opioids. And of that, 17,000, which is a little bit under 40%, were related to prescription opioids. So listed here are a host of efforts that have been undertaken to mitigate prescription opioid abuse and overdose. But what is of most importance is, at least for this talk, will be enhancing prescriber education as it relates to chronic pain management and also prescribing of opioids. So why are primary care providers important? Well, they're frequent opioid prescribers. They represent about a little bit over 50% of the licensed controlled prescribers in the United States, and they account similarly for greater than 50% of dispensed opioid prescriptions. Now, these providers have also reported that they've received inadequate training, or they have inadequate training in chronic pain management, and that makes sense because in North American medical schools, there's about an average of 10 teaching hours on chronic pain management in school. So that's a limited amount of education that they have as it relates to pain management. So it makes sense that they're reporting this inadequate training. So it highlights an area that we can pursue to help supplement their knowledge as it relates to opioid prescribing and also pain management. And one way that this can be done is through educational outreach. So a type of educational outreach is academic detailing. And what this comprises of is one-on-one, face-to-face interactions or encounters with clinicians and specially trained detailers. And typically the detailer is a peer. So it may be a physician to physician, pharmacist to pharmacist, or nurse to nurse. However, that can change. The point of academic detailing, we're providing current evidence-based information to these clinicians. Now, for instance, let's say we were to have a mock example, right? I'm an academic detailer, and let's pretend Todd is a physician. So, hi, it's just going to play out, do some role playing here. So, hi, my name is Chris. I'm a pharmacist over at the University of Illinois at Chicago in the College of Pharmacy. I'm here to talk to you today about opioid prescribing, the newest guidelines that have come out. Do you have a few minutes for me to talk with you today? Great. So, so first, I want to talk with you about the prescription monitoring program in Illinois. And I don't know if you know, but as of January 1st of 2018, all prescribers were mandated to register with the prescription monitoring program. I'm going to speak for you from here on out. Okay, you're done. So let's say Todd lets me know that he has registered to use the prescription monitoring program. However, he doesn't use it because he has password issues. So there's a lack of use, and it's due to him, not being able to reset his password to log in to use the prescription monitoring program. So through the interaction with the detailer and the clinician, you can identify barriers, right? I'm not using the PMP. And how many of you guys know what the prescription monitoring program is? Great, so I won't have to explain that. So we are able to identify a barrier, lack of use, and address that barrier. Now, if you were to say, have a direct relationship as an academic detailer or detailing team with the state prescription monitoring program, you could relay this password issue to them so that they could go ahead and fix it and contact the physician and let them know when that issue is fixed so that they could utilize the prescription monitoring program at their discretion. So that's one useful feature of academic detailing. And hopefully, by doing that, at least in this context, it can help improve the prescribing behavior of the physician or also clinicians as well that utilize the prescription monitoring program. Now, let's say in the same context that the prescription monitoring program has contacted Todd and they've let him know that your issue is fixed. You can use the prescription monitoring program at your leisure. I send Todd a survey about 3 to 6 months after the detailing visit has concluded with a simple question: are you using the prescription monitoring program more often since the visit? With a simple yes or no. Todd checks yes, and he sends that information back to me. So these interventions or programs are evaluated by self-report. And from what he told me previously, he was not using the prescription monitoring program. Now he is, based on the self-reported response that he has given me. So that's one way to evaluate the effectiveness of these programs is through self-reported behavior change. It's not corroborated with the data that is in the prescription monitoring program, depending on if you have a relationship with them or not, but just based on his response, that can help to provide an indicator of effectiveness of the program. So academic detailing has been associated with small improvements in prescribing behavior, and specifically studies have found associations of academic detailing to be associated with reduced prescription opioid mortality, improved opioid prescribing, increased adherence to opioid guidelines, and improved prescription drug monitoring program use. Now, improved essentially means, in this case, as it relates to opioid prescribing, reduced opioid prescribing in the group that received the academic detailing, and improved prescription drug monitoring program use means that there were increases in utilization of the prescription drug monitoring program. Now, opioids are a controlled substance. Prescription drug monitoring programs contain usually Schedule 2 all the way to Schedule 5. So it's fair to wonder if the academic detailing program is associated with improvements in opioid prescribing. Does that effect trickle down? Does it spill over to prescribing of other controlled substances that are non-opioid that are contained within the prescription monitoring program, right? So also in 2018, the CDC championed this educational outreach approach as an effective evidence-based strategy to improve opioid prescribing behavior. So I kind of alluded to this in previous slides, but there's gaps in knowledge regarding how well does self-reported intention to change in this case align with actual behavior changes. Also, we know that there's evidence out there to show that academic detailing is associated with reductions in opioid prescribing and also improvements in the prescription monitoring program use. So it's fair to wonder and to evaluate whether or not there are secondary effects or unintended consequences of these opioid-focused academic detailing programs on prescribing of other non-opioid controlled substances. And lastly, through the role play, having that interaction with Todd and understanding that he does face issues, that there are barriers to using tools that can help inform clinical decision-making, such as the prescription monitoring program, comprehensively identifying these barriers, at least of primary care providers, there's also a gap as it relates to that. So this feeds into my research questions for this thesis, which was to understand how well does self-reported intention to change practice behavior align with actual changes in opioid prescribing after the program. What's the impact of an opioid-focused academic detailing program on prescribing of non-opioid controlled substances? And you can see some examples there, benzodiazepines and so on. And also, what are the barriers that these providers face when it comes to safe and appropriate opioid prescribing in primary care? So conceptually, how does all of this fit? So this framework here, PharmD stands for capability, opportunity, and motivation, all feeding into behavior change. And you know, I wish I could change behavior so that it doesn't have that you. So I know Ernest, you're on the line. This is for you. So I had to adapt the conceptual framework to sort of fit my second aim. As we saw previously here, the blue box represents the intended behavior change. Since I wanted to evaluate and understand are there spillover effects onto an unintended behavior change, which would be changes in the gray box here, which would be changes in prescribing of other controlled substances like non-opioids, I had to make that adaptation. So for aim one, here really wanted to understand by improving the knowledge and capability of these primary care providers, how well does their practice change intentions align with the intended behavior, which is changes in opioid prescribing. Based off of that, does that effect spill over into changes in prescribing of other non-opioid controlled substances for aim 2? And then lastly, for aim 3, identifying factors or barriers that impact physicians or providers' opportunity to change their prescribing of opioids. So that's how all of these aims fit together. So now I wanted to discuss our academic detailing program that was delivered in the Chicagoland region. So there's a whole host of initiatives and activities that are taking place in Illinois to sort of combat the opioid crisis. And one small part of that is this academic detailing program here. So our program was delivered last summer from June to August of 2018. It comprised of 2 visits by trained academic detailers. Visits were approximately 15 minutes in length. So you can imagine that's a very short time to talk with the physician and try to convey this meaningful information to them so that they modify their behavior. A repeat visit was conducted about 6 to 8 weeks following that initial visit. Our target population was Amita Health Medical Group, and it's the 3rd largest health system in Illinois, which serves patients in the Chicagoland area. We want to see providers that were able to prescribe, they have prescriptive authority, and our focus, again, was on primary care. So this comprised of mainly family and internal medicine specialties. The components of our program were as follows. Now, the current guidelines from the CDC, they include 12, right? 12 recommendations to help facilitate safe and appropriate opioid prescribing. However, that's way too many points to try to get through in a 15-minute time span. So we whittled it down to 6, and I'll describe those more in detail next. Also, through our direct relationship with the prescription monitoring program, we were able to obtain data on each of these primary care providers and generate a report card of their past prescribing 6 months prior to program implementation. And this was just to make providers aware of their prescribing in every which way of opioids. So how many patients on a monthly basis were they concurrently prescribing opioids and benzodiazepines? What was the dose? The morphine milligram equivalents, how many of their prescriptions were high dose, which is considered 90 or more? What was their average day supply? Different things like that. So to really give them a comprehensive view of what their prescribing was over the past 6 months. And lastly, each visit concluded with a survey to understand the provider's satisfaction with the academic detailing visit. Now, what this comprised of was providers evaluating the detailer, so were they knowledgeable? Did they have good communication skills? Also evaluating the program. Was this relevant? Did you like what we did? Would you want us to do it again? And lastly, what was the impact of this program on your practice? Okay. All right, so these are the 6 key messages. I love you, Ernest, but I got to move you up. All right. Okay, that's fine. So these are the 6 key messages that we presented to our clinicians over the 2 visits as a part of our program. This is an illustration of the report card that we presented to providers at each visit. And it was a comparison of each individual prescriber against their colleagues at Amita Health and then all other prescribers in Cook County, just to sort of give them an understanding of where their prescribing stacks up within the health system and then also countywide. Here is the actual 10-item provider satisfaction survey. And again, like I said, has information about to evaluate the detailer, the program, but what is of most importance is this practice change intention measure here. Is my practice is likely to change as a result of the visit. This item is going to be very important in subsequent slides. And you can also see the response scale here range from not at all the way to extremely. All right, right on time. So next I'm going to present my findings. So the first aim was to compare self-reported intention to change and actual opioid prescribing behavior following this opioid-focused academic detailing program. So we conducted this was a quasi-experimental pre-post study utilizing a difference in difference approach. I will talk about the difference in difference in a few slides. We used prescribing data from the Illinois Prescription Monitoring Program. They provided us this data on all of the providers that we saw, and then this design and data source will be the same for the next aim as well. So we included Amita providers who had at least one academic detailing visit. We excluded resident physicians and also pediatricians. So our intervention group or change group here is indicated by the delta, the triangle in front of group here. Providers who self-reported very or extremely likely to change their behavior on the provider satisfaction survey were categorized as providers with an intention to change. And those providers that self-reported not at all, slightly, or moderately to the item were categorized as no or low intention to change. And this is our non-change group. So our study outcomes were change in the mean monthly number of total opioid prescriptions and also high-dose opioid prescriptions. And these outcomes were measured 6 months prior and 6 months after the academic detailing program. So the difference here. So I would ask that you pay attention to the graph here on the right-hand side. So essentially what this is exactly what it says, is a difference in the differences, right? So we have 2 groups. And we have an intervention and we have a control group. We have 2 periods. We have a pre and we have a post. what the difference, it's a very simple calculation. You too can do it at home. And I will walk you through how this is calculated. But essentially, it's going to be a subtraction of the it's going to be a subtraction of the post from the pre in the intervention group. That's your first difference, okay? Then it's going to be a subtraction of the post-period value from the pre-period value in the control group. That gives you another value. Then you take the difference between the intervention and the control group, and that is your treatment effect, or this B3 here that you can see. That's the treatment effect. Any questions on that? Did I explain it clearly? Great. So I'm going to take that as a yes. And how we can estimate the difference in difference is simply through this regression model that is here for you. Okay, so to describe my sample, we have 149 clinicians total, 72 in the intention to change, 77 in the no to low intention to change group here. There's a host of characteristics such as sex, years of practice, clinician type, and specialty. And we can see that there are no differences between the two groups. Okay, so we can see here that, or what is of most importance, I've highlighted the pre-value for both groups for both outcomes. And what is interesting here is that based on those who responded or in the intention to change group and relative to the no to low intention to change group is that the prescribing is higher, right? The prescribing is higher in the intention to change group relative to the no to low intention to change group for both outcomes, right? So we can see that this one question was able to sort of distinguish between high and low prescribers, or prescribers that prescribe opioids more frequently and less frequently. So I'm going to walk you through the difference in difference calculation. So you can see that the delta is listed for both groups and for both outcomes. So let's look at total opioid prescriptions. So we can see that the difference from post to pre is a negative 0.47. And we can see that in the no to low intention to change group, post minus pre is a positive 1.01. So if I've done the math correctly, it should be a negative 1.48 as for the difference in difference estimate. Similarly, if we look at high dose opioids, we see that the delta is negative 0.57, and for the no to low intention to change group, it's negative 0.07. Now, I'm sure as most of your parents have told you that two wrongs don't make a right, but in math, two minus signs make a positive. So if you take negative 0.57 minus a negative 0.07, like that was good, minus a 0.07, you see that the difference in difference estimate we will get is a negative 0.50. So without further ado, we see that what I predicted was actually correct here on the screen. So how to interpret this is that there was, so the difference in the difference yielded there was a reduction, or opioid prescriptions was lower by 1.48 total opioid prescriptions per month per clinician relative to the no to low in the intention to change group relative to the no to low intention to change group after the academic detailing intervention. And similarly, there was a reduction of 0.5 high dose opioid prescriptions in the intention to change group relative to the no to low intention to change group after the academic detailing program had concluded. So what's interesting here is that if we look to the right for the difference in difference in the restricted subgroups there, you'll see that the estimate is nearly 1, right? It's much lower than it is at negative 0.50. I can't talk. So what the restricted subgroups were providers with any sort of opioid prescribing or high dose opioid prescribing in the baseline period. That's 6 months prior to program implementation. So we can see specifically for providers who prescribed at least one high dose opioid prescription in the baseline period, when we look at that sample of providers in both groups, it's a reduction of nearly 1 high dose opioid prescription per month per clinician in the intention to change group relative to the no to low intention to change group after the academic detailing program has concluded. So what does this mean for future academic detailing programs? I'm trying to put the implications in for those that are going to be conducting these programs in the future, since this is a method that is endorsed by national agencies such as the CDC to improve opioid prescribing. So This study demonstrates that self-reported practice change intentions do align with actual opioid prescribing behavior after the program. Additionally, by taking a targeted approach or only looking at prescribers who had who prescribed high-dose opioid prescriptions in the baseline period, we can see that taking a targeted approach may be beneficial for some programs. If they can't see a large number of clinicians, if they can only see a limited number of people, it would make sense to deliver the intervention to those who may need it the most by looking in the baseline period to identify, looking at their past prescribing behavior. Also, as we saw in the results, that this item was able to sort of delineate between high and low prescribers, or frequent and infrequent prescribers of total opioids and also high-dose opioids. So using this measure can provide an initial indicator of academic detailing effectiveness. So now let's say some academic detailing programs are resource constrained. They don't have direct relationships like we have with the Illinois Prescription Monitoring Program to get this data, or they may not have someone to analyze the data to assess changes. So by just using this single item measure as a proxy to indicate effectiveness of the program could be useful for those academic detailing programs. As I stated earlier, that also could be a limitation. So utilizing this single item as a proxy for behavior change is a limitation of this research. Also, we took the approach of delivering this intervention to everybody that could prescribe opioids. So we did not condition on past behavior to determine whether or not you would receive this intervention, because you could, although you may not have prescribed opioids in the baseline period, you could essentially prescribe opioids in the future. So we wanted to arm these clinicians with the knowledge and information so that they could safely and appropriately prescribe opioids going forward. And also, this was a single center in a single urban area, so generalizability to other health systems and other settings, such as rural settings and other specialties, could be an issue as well. So next, for my second aim, we wanted to evaluate the change in prescribing of non-opioid controlled substances following the academic detailing program. So providers in this study were AMITA providers who received at least one academic detailing visit. So this is our change group here. And our control group were providers from DuPage Medical Group and Loyola Medicine. I think everyone's pretty familiar with those two health systems. So they're in a similar geographic area and likely to see similar patients because we also included providers of similar specialties, so family and internal medicine as well. So it's likely that the patient mix wouldn't be differential between our change and non-change group. Also excluded in this study were resident physicians and pediatricians as well. So similarly, we want to look at the change in mean monthly number of benzodiazepine prescriptions, non-benzodiazepine sedative hypnotic prescriptions such as Lunesta and Ambien. These are known as the Z drugs, and carisoprodol prescriptions, some Schedule 3, I believe, muscle relaxer. So we looked at these outcomes 6 months before and 6 months after the program, and a similar analytic approach was used, the difference in difference. So to describe by sample, we had 550 clinicians total in this study, 151 in the 80 exposed group and 399 in the control group. We can see, aside from sex, that the years of practice, clinician type, and clinician specialty are all there's significant differences between the groups when it comes to these characteristics. There's more physicians in the control group than they are in the 80 exposed group, and then it's really polar opposites between clinician specialty for family and internal medicine between the two groups. Okay, I should have made that orange darker. Okay, so here, what's most important here is the finding related to benzodiazepine prescriptions, okay? So we see in the baseline period that in the intervention group or the exposed group, it's 24.10 and 21.94 in the control group. Now, the absolute number of benzodiazepine prescriptions in the post period for both groups decline, right? Absolute number declines. And you can see the delta, the absolute delta is actually higher in the control group than it is in the AD exposed group. So when we do the math to get the difference in difference estimate, the difference in these declining rates is nearly one benzodiazepine prescription per month per clinician higher in the intervention group compared to the control group following the academic detailing program. Okay. Now, if we compare that to total opioid prescriptions, we see that the difference, there's a reduction, right, or it's lower. Nearly one opioid prescription per month per clinician, lower in the AD exposed group relative to the control group after the academic detailing program. And these estimates are magnified when the groups are restricted. And again, to define restricted subgroups, it's baseline prescribing of the outcome clinicians who prescribe benzodiazepines or non-benzodiazepine sedative hypnotics in the baseline period. So we only include those physicians or clinicians to generate this difference in difference estimate here. Again, so what does this mean for future opioid-focused academic detailing programs? So this study does demonstrate that there can be secondary effects, unintended effects, unexpected happenings as it relates to prescribing of non-opioid controlled substances, so such as benzodiazepines. So these programs should just be aware of that as they're developing and implementing specifically opioid-focused academic detailing programs. These programs should also, as a result of these findings, they may want to consider incorporating education on safe prescribing and also misuse and abuse of non-opioid controlled substances like benzodiazepines. And what's growing more is abuse of gabapentin with opioids, increasing the risk of opioid-related mortality. I know gabapentin is not something that's captured in in Illinois state prescription monitoring program, but I believe in states like Kentucky, it's captured in their state prescription monitoring program because it is becoming abused more as a risk factor for opioid-related mortality when used concomitantly. But it comes with a trade-off, including this information in addition to information on safe and appropriate opioid prescribing. So programs should consider, or they need to weigh the feasibility of delivering all of these amazing all this amazing information to these clinicians, and prioritize what messages should be delivered. Because as I stated earlier, there's only about 15 minutes on average to visit with these clinicians. So you have a very short time frame to get across many messages that can improve their prescribing, but you need to make sure that it's feasible, and then also to prioritize what messages you want to convey in that time period. So limitations of this study would be differences between providers, as we saw in that first table one. These characteristics, however, are immutable, time invariant. They're held within each prescriber. Again, all these immediate providers, they received the intervention not based on their past prescribing, right? Because they could prescribe opioids in the future. There may have been some differences that we couldn't account for that are within and across the health system, and also patient mix. However, patient mix we wouldn't think would be an issue because these providers are of similar specialty, and also they're in a similar geographic region. And also generalizability. This was, at least in the academic, those who received the intervention, single health center, single sort of specialty primary care in an urban setting. So that'd be generalizable to, let's say, clinicians in rural settings. Okay. Lastly, final aim here was to identify barriers to safe opioid prescribing among primary care providers through this academic detailing program. So this was a qualitative analysis of field notes, documented information after each of the academic detailing, after each of the academic detailing visits. We collected information or analyzed information from all the AMITA providers who received at least one visit from our 10 academic detailers. So Mary and myself were academic detailers, and then we also had 8 PharmD students, 6 P2s, and 2 first-year PharmD students. So all the academic detailers were encouraged to document comprehensively each visit after it concluded. So whether it's in their car or in the office, to immediately recount the visit so that Mary and I could go through those accounts and sort of understand what exactly is taking place, because we can't be at all of these visits. So that was sort of the rationale behind that. So we conducted a thematic analysis to identify common themes that were related specifically to safe and appropriate prescribing of opioids. Two reviewers independently coded the data. So myself and Sorette Tilton, a P4, she's now a P4 pharmacy student on rotation right now. Lisa, Dr. Sharp, was our expert reviewer to handle any sort of discrepancies or questions we had as it related to coding all of the data. And these codes, the codes were subsequently collated into themes, themes that identified barriers to safe and appropriate opioid prescribing in primary care. So these are characteristics of our providers. So we had a total of 186 providers that we reviewed the accounts of each visit for. The majority were female. Majority were also physicians, family medicine specialty. Years of practice, median years of practice were 12, and median visit length was about 15. There we go. All right. So barriers. So the barriers to opioid prescribing that we identified are listed here in order of frequency that they were reported. So, for instance, knowledge gaps as it relates to naloxone. So some providers didn't know that they didn't have to necessarily prescribe naloxone, that you could go to any retail pharmacy and you could obtain it there. So that was something that they did not know about. Also, naloxone doesn't just come in a nasal spray, it also comes in an auto-injector. Some of this information was not known by some clinicians as well. Also, some providers asked us, well, where does tramadol fit? Is tramadol an opioid? I'm not sure. I prescribe it because I don't, it's not addictive. So, tramadol is an opioid, but they, some clinicians indicated that, they may not have, they were not aware of that. The role play that I did with Todd at the beginning about the prescription monitoring program, providers just indicated to us that, hey, I'm not using it. I don't find it to be useful. Some providers wanted to use it, but there were issues such as password or registration. They cannot reset their password. They were not registered. Time was an issue. In Illinois, we now have a delegate process to where prescribers can delegate access to someone else, a nurse practitioner or someone else, to access the PMP on their behalf. When it comes to patients, providers said they sometimes receive many phone calls from patients just asking for refills on their Norco without even being seen. So some providers didn't feel comfortable refilling these medications without having an assessment of the patient to understand, was this prescription medically necessary? Insurance, when it comes to coverage and also utilization management policies, the Norco may be really cheap, Percocet may be really cheap, but when it comes to lidocaine patches, diclofenac gel, physical therapy, occupational therapy, Tai Chi even, these things may not be covered, or there may be some prior authorization that the clinician has, the prescriber has to fill out in order to, for patients to have access to these medications. So that was a huge barrier for clinicians that they indicated to us. Also, believe it or not, prescribers said that they did not believe, some prescribers, not all of them, some prescribers indicated that they did not believe in the opioid crisis. That was fake news. It was some government manufactured story, right? Also, personal experiences. Some providers who said that, they had a family member or loved one afflicted with opioid use disorder succumb to that, and that sort of shaped how they prescribed opioids, made them more conservative opioid prescribers or prescribers of opioids as a result of having these personal experiences. And uniquely, by seeing nearly 200 prescribers, we were able to uncover and identify consistent system-wide or health system-wide issues that providers relate to us. The most prominent one being that providers, these were primary care providers that we saw. And at this health system, there are clinicians trained specifically to manage pain specialists, right? But I don't know the exact number, but bear with me here. Let's say the ratio of primary care providers is 10 to 1 pain specialist, right? So if all of the primary care providers, which this was something that was occurring, if all of them are just referring all of their patients who have chronic pain to the pain specialist, well, one, that's going to create a backlog or a time lag from when the referral happens to when the patient is actually seen by the pain specialist. So the primary care provider is having to manage these patients regardless. And then depending on the patient's insurance, when they receive a referral to see these pain specialists, there's only a limited number of times you can see the pain specialist, right? And then you get kicked back to the primary care provider who is then managing their chronic pain. So getting some sort of clarity on what the primary care provider's role is and can be as far as being able, having the skill set and also the confidence to manage patients with chronic pain was something that was identified and ultimately relayed to the health system for them to be aware of this and make the necessary changes or improvements to facilitate that. So as I alluded to, leveraging these academic detailing visits to understand the scope of this but barrier to safely and appropriately prescribing opioids in primary care is something that these future opioid-focused academic detailing programs can be aware of. Also, when they're developing programs, incorporating strategies to address the barriers that were identified from this research, such as the knowledge gaps. These are something that can be addressed directly. You would think that these providers would be aware of naloxone and things like that, but clearly, some of them aren't. So incorporating information like that into your educational outreach. Also, around the prescription monitoring program. The prescription monitoring program, it seems, since I've been practicing, which has only been a short amount of time, but has been changing in a few short years. I was at work the other day and logged onto it and was shocked to see the interface has now changed. And it's more user friendly, and there's more useful information that's captured in the prescription monitoring program. So incorporating things like that into the academic detailing program. And to piggyback off of the prescription monitoring program point, establishing and maintaining partnerships with relevant stakeholders, such as the state prescription monitoring program, we would not have been able to resolve the we had many issues related to use of the prescription monitoring program. So by us having a direct relationship with them, relaying the provider's information to the prescription monitoring program and whatever their issue was, whether it was registration, password, having a delegate to access the PMP, all of those issues were directly relayed to them, and either on second visits or follow-up visits with these clinicians, they were able to let us know to say, hey, the prescription monitoring program, they contacted me. They let me know that my password is fixed, and now I can use the prescription monitoring program at my leisure. So really having that value added of not just saying, hey, I hear you have password issues, taking it to the next level and relaying the issue to those who can fix it, so that these prescribers can better prescribe make better clinical decisions as it relates to a controlled substance. Also, having a relationship with the health system. Without Todd and Simon establishing these relationships with Amita Health, just getting our foot in the door to see these nearly 200 physicians. We've replicated something similar in Southern Illinois, and by just trying to call these offices and schedule visits, it was not very easy, was it, Mary? Right? So once we established partnerships with health systems all across, at least in Southern Illinois and here in Chicago, it was able to expedite the process and see a lot of providers and provide them with this information. So we had to rely on the detailer's recall and written account. So they typed this information into a Google software application, and the visits weren't recorded, right? So it was based on whatever the detailer thought was important in their mind to document to document for us to review. Also, providers weren't directly asked, hey, what barriers do you face as it relates to safe and appropriate opioid prescribing in primary care? They weren't directly asked that, but through reviewing the information that we had that the detailers documented, it was clear and apparent what were issues that these providers face as it related to their as it related to opioid prescribing within their health system. Some detailers provided a lot of detail, pages upon pages of information for each sort of individual visit, and some did not. So there was some variance in the level of detail and also length of each of the field notes of the accounts of the visit. And then also, again, this was just a single center, done in a single center and single urban area within primary care. So overall implications and direct implications of this work that I have done. So if you don't write, nothing will change. And I think can you see the typewriter? If I wrote this on a typewriter, for those of you that know my lack of typing skills, I'd still be typing my thesis right now. So if you don't write, nothing will change, okay? So we can see, as of August 9th of 2019, signed into legislation here was this House bill, or HB 3097. You can Google that on your phone. It'll take you directly to the link, and you can read all about what's in this legislation. But essentially, these findings were used to help influence signing of this legislation, specifically for Medicaid prescriber education, not only of opioids, but of also prescribing of or extending to other disease states as well. And I think that's Todd and Simon actually standing behind JB as he's signing that into legislation. Speaking of Todd and Simon, these findings were also useful in helping to secure $2.3 million in grant funding from the CDC, and that doesn't even count the additional funds we received from other state agencies to continue this groundbreaking work of academic detailing in the state of Illinois. So the point of all this is to hopefully help improve opioid prescribing in the state of Illinois, statewide. So with that, I will conclude with, if you have any questions.
Fire questions addressed.
I just have a point of clarification, Chris.
Sure.
You mentioned that one of the barriers was providers not believing in the opioid crisis. Now, was that they didn't believe it existed at all, or was it that they didn't think that their patients were impacted by it?
So both. So there were some field notes I can show you when I get back.
No, I know.
But okay.
I felt like I just wanted you to make that point.
Sorry. Yes. So to be clear, providers indicated to us, one, they did not believe in the opioid epidemic, and also they did not believe that the opioid crisis impacted or had an impact on their practice for their patients. For instance, if providers saw a lot of elderly patients, right, they would not think that this crisis would be affecting their population that they saw. Thank you. Well, Katie, yeah. Hi, Katie.
Hi.
Hey.
What was the mean number of prescriptions prescribed by these providers in the intervention at baseline?
For which study? Oh, for
In general.
in general. You said
There's about there's a mean of like one prescription. Like your results, your different studies found that there was one prescription decrease per provider per month.
right.
That's about 12-ish, right?
Yeah.
So is that a significant number? And that kind of depends on what your baseline is, right?
Right. Trying to see, do I have that?
And then while you're looking for that, my next question is, did you look at the difference in MME or day supply?
For opioids, we did. And then what was your question based off of that?
Was there a
Yes.
decrease?
Yes.
Did you
So
look at MME or day supply?
so there was no change. So there was no significant difference in day supply between our intervention group and control group. That number is 18. So it was about 18 day supply for both intervention and control. No significant difference. MMEs, though, there was a reduction of nearly 2 MMEs on average. So now that was a statistically significant finding. However, I don't know if it's very clinically meaningful because, again, going from 90 to 88 on the high dose, it's still pretty high dose on a daily basis. To answer your question about the baseline prescribing, yes. That's in the intention to change versus non-intention to change in AMITA by itself. Yes. No problem.
Chris, it might be worth mentioning, was the supply an issue in the Chicagoland area or in Southern Illinois? Where was a bigger problem?
So I don't know if I would characterize it as a problem, but day supply was much longer in Southern Illinois relative to Chicago.
Right, so that might be an outcome of interest, more of interest if we're trying to impact that
right.
in Southern Illinois, and this
relative.
is in Northern Illinois.
Right, yes. Thank you. Hi, Kat. Yes.
Thank you for your presentation.
Thank you.
So your 80 exposed group, that's just at least one 80 visit, right?
Yes.
Do you guys see a difference between like one 80 visit versus?
So you mean looking at a group that received 2 visits?
Yeah.
I didn't look at that. Did we look at that? I didn't look at that. No. I'm sorry. Sorry. Thank you. But good question, though. Thank you. Yes, Bob.
Are these controls just like a random sample from the CMC?
No, these controls are not a random sample. They're a non-random sample. So these providers in the control group were identified through publicly available information from the health system's website. So from DuPage Medical Group and also from Loyola, we identified those providers that were of primary care, specialized in primary care, which then turned out to be subspecialties of family and internal medicine for both of those groups.
Are they part of the AMITA health system?
They are not. These are providers that were unexposed to the academic detailing intervention and not affiliated with our intervention group.
So my question is, you alluded to this, how it's like this is one health system might not be generalizable to other health systems.
Sure.
And there's different populations that go to the different health systems as well. Do you know of any like policies specific to like AMITA that are around like prescribing? Because I know some health systems, they take it a little bit more serious, and they'll send out, information to their prescribers on those kind of things. Do you know if there's any like policies in like AMITA that may be different than like?
So two-part question. So I do know of policies that are in AMITA. I don't know if they're differential between the AD exposed and the control group. So specifically working with AMITA's pain specialists, they have developed a, I believe, 14 or 15-page opioid playbook to disseminate to all of their primary care providers that is largely based on the CDC's opioid guidelines to help them better practice or better prescribe in primary care. Additionally, I believe they have this quarterly, I don't know if the quarterly meeting that they have is specifically for opioids, but they do have a meeting that they do have quarterly with their providers or to sort of keep them up to date on issues that are going on. And I know when Mary and I visited one of the health systems in Hinsdale, that is specifically a teaching, one of their teaching locations for their resident physicians, they were having a grand rounds around opioid prescribing for their residents. So I know that they are doing various things specifically related to opioids to ensure that not only their resident physicians, but also their current physicians are updated on the most current evidence.
Without question, specifically during your point of data collection, were you aware of any differences in those systems?
No.
Because that's important. Then you can talk about what they've done afterwards, but in terms of interpreting these results, and Dr. Kaling keeps raising his hand.
Hi, Greg.
Hi. I have a follow-up on Katie's question. So when during the day supply, was it the self-reported?
No. So all the information we received or obtained was from the Illinois Prescription Monitoring Program. So that was none of the measures here, this prescribing data came all from the PMP. None of it was self-reported. The only thing that was self-reported was whether or not they would change their practice behavior based on the visit.
I'm curious though about that. In that system, do people enter a day supply, or is it like calculated?
So it's calculate, the PMP calculate that day supply based on the quantity and the directions, the quantity and the dose. I have to go back and look at the columns. But when they send it to us, correct. Yes. There is a way to calculate it. I don't remember offhand. I haven't looked at it in a long time. But yes, all of this information is calculated and provided to us by the prescription monitoring program. The providers are not self-reporting any of this information.